Going on now until September 10th at noon, we are running a free giveaway of our Movement Foundations course and exercise database. Visit our Instagram account, Resilient PPT, to learn more and enter. If you've already purchased these prizes, we'll get you our next course or provide a future discount of the same value. Either way, we'll make it work so you can benefit as well. Hope to see you there. Before today's episode, I want to ask for your interest. We'd like to open our Keep It Real episodes up to you, the listener, and have discussions on topics driven by the content of this podcast and our social media. If you're interested, we'd love to hear so by dropping us a message on our Instagram. Our handle is ResilientPPT, ResilientPPT. Thanks.
Welcome to the Resilient Performance Podcast. I'm hosting today, Trevor Rappa, here with my partners Greg and Douglas on Keep It Real number 7. Is that what this is?
Six.
No, wasn't it? Okay.
It's 6.
I got to look that up before we do this. One of the things that we want to talk about first was something that young clinicians struggle with, and we always get these questions from our students that we have, is how do we choose the right exercise? And kind of what is the right exercise, as if there's only one intervention based upon what we're seeing that's applicable, when in fact there's millions, and you can choose pretty much anything as long as you have a good rationale. So you guys want to start talking about that?
Yeah, and you know, when people say like young clinicians, it's not like we're like these master clinicians and we're like, you know, oh, Padawan, like we're going to show you. I think that's a great question, because I don't know if there's a way to definitively answer it. I'll go back to, you know, some 80s, 90s movies, analogies. If you remember from the movie City Slickers with Billy Crystal, there's a point where you know, two of the members of the group, I think, are these brothers that own like an ice cream company. And at one point they're eating dinner, you know, with Curly passing around the, you know, the pot of whatever hot food that they just made. And, you know, these two brothers say, like, we can pick the best ice cream for any meal. And Billy Crystal's like, okay, like, I'm going to challenge you. And he names like some random meal. It was like sea bass and something else. And they look at each other and they're like thinking really hard for a couple seconds. And then one of the brothers says, rum raisin. And he takes a deep breath as if like he just answered this question. They high five each other. And it's like, how the hell do you know that that's right? And they said something like, well, you know, when you've sold this many millions of dollars of ice cream, you know that you're right. But when it comes to exercise, how do you really know that you're right? I mean, like, you can have your test retest. So you're testing something you think is meaningful. It could be range of motion. It could be you do a certain exercise or activity, like you run. My knee hurts when I run. You do an intervention and the knee doesn't hurt anymore. Now, maybe the knee doesn't hurt in that moment. Maybe the knee is going to hurt when they go home, and then, or, you know, 24 or 48 hours later. So even in that one session, like, did you make a change that was meaningful? It's hard to know that. I don't even know if we have ways to truly know that. It's like you have to have some test retest, because it's not going to be perfect, but you have to have something. And then a lot of times, you know, and this is kind of like a dirty secret to think about what we do. We think that what we're doing is so like kind of specific and perfect that, like, you know, oh, like we have such an influence on people. And I think that, you know, if I'm being honest, I don't know if you guys feel differently. I feel like it's hard to say like an exact percentage, but the majority of like what I feel like I do with people is I give them permission to move. Because nowadays, like, if anything hurts, everything is so pathologized. It's like, well, you know, like my knee hurts when I run. So they either stop running on their own, or they go to another medical provider who says, oh, like, you know, you shouldn't run, you shouldn't do squats. Like, there's a million things that you shouldn't do. And sometimes, like, if there's a really, really acute injury, there's tissue damage. Yeah, like you should rest. But I think a lot of times, like, rest and just cutting off that activity is overprescribed. And so even if you just have somebody do something to prove to them that it's not dangerous, that alone can be very, very valuable and therapeutic. And you didn't really do anything great. You just gave people permission. So at least for me, like, what I'm trying to do with people is I have kind of like an assessment, and I'm looking at, okay, like, do you have any gross movement deficiencies? And people can argue about, does that even matter? Like, I think that you're a human being before you're a basketball player, a track athlete, before you're a grandparent that wants to pick up a kid. Like, I'm not looking for, do you have, 40 degrees versus 38 degrees on one side or the other? I'm looking at, like, do you have something? Are there any egregious things where it's kind of like, that kind of, put your antenna up, try to address those. And then, okay, like if you have trouble in a painful activity, let's assume that we got rid of that low hanging movement fruit. Let's try that activity. If it's pain-free, great. Now we'll try to get you on a program to figure out like how to maintain that or build up to your old workload. So the whole, load management thing, I think load management is important and progressive overload, but I think that you have to address, the underlying movement quality aspects of that, even though it is an ambiguous term. And then if you do your table stuff, you do your test retest, and the table stuff cleans up, but they still have pain or lack of confidence in whatever activity they care about, then it's like, how do we duplicate that activity as much as possible and maintain as much of a training load as possible without exacerbating symptoms? So if their knee hurts when they squat, it might be in a back squat, maybe in a different kind of squat it doesn't hurt. Or if something hurts when they run, well, maybe it only hurts after 2 miles, in which case we'll cut your mileage down. Maybe it only hurts at a certain threshold of speed. Maybe, any kind of running hurts, but if we do a skipping drill or a progression to running, or even a low-level plyometric drill that somewhat mimics running in terms of the elastic qualities and stuff like that, that doesn't hurt, we'll do that. So it's like, how do we address the global stuff detached from the activity? And then how do we address, how do we get as close as possible to what they want to do, and then develop a good program to build up tolerance? But even with those things, it's impossible to say, like, if what you did, how do you evaluate it? Because there's so many ways to do that. So
yeah,
it's like, go ahead. Yeah.
Like a couple of that you said that stuck out to me in terms of like going back to what the root of that question is. It's like, why do we choose something? And it's always based upon an assessment of what we think one of the major limitations or one of the major factors that could be preventing them from moving efficiently or effectively or safely or whatever. And then taking that, orthopedic or more typically biomechanical evaluation and choosing something that should improve it, whether it is like a range of motion or mobility restriction or like elasticity with a skipping example or strength or whatever, and then retesting it and seeing if there is an improvement. So from the assessment, there's so many things that you could choose. It just based upon like what lens are you actually viewing, what is causing that limitation, or what is causing the reason that they're in and seeing us. What do we think is kind of causing that? So our intervention is always based upon what our own rationale and what our own thinking is. But that doesn't mean that like I'm right. Somebody else could choose a completely different intervention for a completely different reason and get the exact same outcome as me. So just because like something worked doesn't mean that something else wouldn't work too. And I think that's an important thing for people to see. It's like, just because the thing I chose did get the effect I wanted doesn't mean that's the only thing that could have gotten that. Because people, especially online, people start speaking so dogmatically, like this is the only thing that you can do for this symptom, or something really just a blanket statement like that, which is so misleading to people. If you don't understand that everything works, there's so much context, like you're describing, Doug, that influences why things work. And that's so many reps of treating patients has helped us understand like what that lens is and what are some of the different factors that can influence how an intervention is actually perceived by a client.
Yeah, and I remember this, it makes me think back to when we were all students, and I remember certain like nuggets of my clinical experiences just kind of pop out, and like I remember more clearly, and one of them was with Alan Groover in Arizona, where it's almost like he had to sort of draw out an answer from me of like, okay, well, what are they missing on the table? Okay, what do you want to do? It's like, well, there's a million different things I could do. So how do I choose what I want to choose? So he's like, doesn't matter. Choose one. Just choose one. It doesn't matter. Pick one. Try it. If it doesn't work, then pick a different one. And you can do that over the span of weeks too. Like, it doesn't have to be in that one session that you're fixing everybody with one exercise, because it's just not really how it works. So, I remember picking some sort of reaching exercise for somebody's shoulder, And it was like, looking back, I'm like, that was kind of a dumb exercise to pick. Like, dumb because I wouldn't pick it now, but it still fit the rationale of why I would want to choose that exercise. And I think that then leads to when we have students now, they're going back to the to the same way that I was, or you guys might have been, where it's like, okay, you picked this specific one exercise. Like, why did you pick that one exercise? And for me, my answer is always now, well, what does this exercise do? Like, what are we doing here in this exercise? What's the goal of the one or two goals that we're trying to achieve with this exercise? So let's say it's some sort of hamstring exercise to get more hip extension or whatever it is. Um, they might have that answer, like they're limited in hip extension, so I want to do something to activate the hamstring. It's like, okay, so that's what this exercise does. Now you could do 10 different things in the same exact position in different variations, different heights, or whatever, and they're all correct. And then it goes just back to what you're saying about us just having reps, and that's what students don't have. But it's like so daunting as a student of like, I have to pick the thing, and there are so many different things, like you said, and then it's also a matter of at the right time picking the right thing, because people will poo-poo things like clamshells or things like that, and it's more a matter of like when are you using clamshells, or why are you using clamshells. If it's somebody had hip surgery post-op, like they probably need to do some clamshells initially, like to just desensitize the area, get some muscles working. Like, who cares? It's fine, it doesn't matter. Like, they're going to graduate from that in a week or two or three anyway, but that's the initial jumping off point, and you have to give them something to do. They need exercise, they need to move, and that goes back to what Doug, you were saying. You're giving them the okay, or you're giving them the thumbs up to move in whatever way, and it just might be this clamshell exercise because that's where they're at. And then like I would then say, like, probably shouldn't be doing clamshells week 40 after an ACL surgery. Like, you probably shouldn't be. No, you probably should be doing something else that's a little bit more bang for your buck at that time. So something can, like you said, Trevor, everything works, but it has to be for the right reason at the right time. And then then you can kind of just pick whatever you want, as long as it kind of satisfies those two factors.
Yeah, maybe this is like a philosophical question, but it's like, who's the arbiter of whether it's working? I mean, to me, that should be the patient. And I think that people, are usually pretty good about deciding what they like and don't like. So we don't need, like an expert to tell us what computer to use. We're using Zoom right now. Like, we didn't, have like an authority on computer science tell us to use that. We just kind of figured like it works for our purposes. There could be something better, but we're happy with it. You buy your car, like all these things. You can do some research, but not that like medicine is a perfect analogy, because there's some like very complicated disease processes where like something could be wrong with you and you can't perceive it. But for what we do, it's actually like pretty clear cut. Like, they're in pain, and only they can tell us if they're in pain, and there's no objective test for it. So if you do something and it reduces their symptoms, they're not as much pain, like, you can ask them, because there's no better judge of that than the patient in front of you. And then their function. I mean, we have tests of function, but if we say, okay, like, what are your goals? Well, like, go try the thing that you were afraid to do. Can you do it now? Yes. Like, do you feel confident doing it now? Yeah. Like, only they can really answer that. I'm not saying every aspect of medicine should be deferred to the patient, because there are some things that do require much more like objective testing. But for what we do, there's a lot of subjectivity, and that's why like even conflating medical diagnoses with physical therapy can be problematic, because like, no matter how important we think we are, we're not actually directly addressing a medical diagnosis. We're trying to improve function and get people to move systematically, and there's an expertise required to do that safely and appropriately. And I think that we often feel like, as a profession, that we have to like kind of pretend that we're doing something that we're not, when what we're doing is still pretty important, and just embrace that. But I think that like the patient is the arbiter, not us. And I think if we're very clear about like, hey, you drive the train here, you tell us if what we're doing is working, it makes the process that much easier than because otherwise, like, I don't know who the judge is. Like, I don't think it's us. It really is them.
Yeah,
and I think I was just gonna say, Trevor, I'm now more like, commonly with the right patient, it has to be the right patient. I'll ask them at a certain point, maybe I've seen them a few sessions or a couple weeks or whatever, And I'll actually ask them now, like, how do you think this is going? Like, what do you think you need? Like, are there things that we aren't doing that you think should be used, or you found helpful previously, or and I mean the answer is typically like they're typically pretty happy, and maybe they'll say like, I really liked when you did this one thing, this one manual technique that maybe we haven't done as much recently or whatever. Like, I really liked when we did that, so I might do it more. But part of it, like you said, Doug, is like, we're here for them. Like, I don't care about what the internet tells me, what I should or shouldn't be doing. Like, I want to give the patient what they need. And if they're telling me like, I know this thing's going to help me, or I feel like it has helped me, and I need more of it, like, I'm going to do it for them. Obviously I'm not going to be doing something that is dangerous or sort of doesn't, fit into my bucket of helping them, like out of my scope or whatever. But that's something that I feel like I'm doing more of now. And it goes back to, it has to be the right patient, because I wouldn't do that with every patient. Maybe the patient who is being told by 5 different people things that they need to be doing, which is hard enough to deal with. Like, you kind of have to stick to your guns, so to speak, and really go based on like your experience and your knowledge, instead of saying like, what do you want? Because what they want might be like, I just want to lie on the table and like put my leg up and throw a bag of ice on there because that's what this person told me I should do. So again, it has to be the right person.
I think so much of like the better we get at listening to clients, to know to understand what they want to do and what they think is kind of going on, helps the interventions that we choose and the things that we do like so much, because ultimately like they know the function that they want to have, and they have, whether it's right or wrong, they have some idea in their head. And the more we can ask them good questions about the things that they're experiencing, the better information we'll get. And I think the quicker intervention or the more direct intervention that we can give them. Like, I had somebody last week who his left low back was tight when he squatted, and one of the things that he wanted to be able to do, he felt like he couldn't rotate. And I was like, you can't rotate in what positions? Just give me an example of that. And he said when he does the chair position and rotates in yoga with his significant other, that he just feels his left low back restricting him and limiting him and all that kind of stuff. And I was like, okay. He had a bunch of other, hip rotation limitations, trunk rotation, whatever. I just had him go on his stomach, and I put my forearm in his QL, and he goes, oh, yep, that's it. And after a couple of minutes, he stood up and he could rotate and he could squat, and his back felt a lot better.
But manual therapy doesn't work, Trevor, so I don't know how you did that.
It's like, well, why did that work? And it's like, I can make up a terrible reason that is going to be confusing and make it sound like I'm doing voodoo, but we give them simple explanations and help them improve their function, which is what this person's coming in looking for. They're not coming in looking for in-depth explanation as to all the different things that possibly could be going on. They want to improve their function. And if we listen to them and understand what they're telling us, we can help improve their function sometimes relatively quickly.
Yeah, and even with that, I mean, it's, it worked. Like, you don't know if in 24 hours it went back to being the way that it was, but you don't have 24 hours with them. So you can only do what you can do. And I want to go back to what you were saying, Greg, because I think that some people can kind of misinterpret maybe or overly extrapolate what we're saying and say like, oh, well, all these guys do is like whatever the patient wants. And so like an extreme scenario would be like, you have somebody coming off an ACL surgery and like all they want you to do is, compress their knee and do knee mobs for 10 months. And like, maybe there are some people where that's what they want, but I would say that it's a combination of what do they want, but you also have to ask the right questions too and put them in the right scenarios to help them see things. And so if somebody says like, I want to go back to playing whatever Division I basketball, and all you did was rub their knee, at some point if you're being responsible, you have to put them in a scenario that somewhat like mimics, what they're going to do on the court. And, obviously in a very progressive and safe way. And so if you get someone in like 4 months after a surgery, they can't, on a single leg jump onto a 1 or 2 inch box. You could say, okay, well, we've been doing what you want, but your goal is also to play basketball. So you're seeing that like, we have to kind of reconcile those two things. So you have to reconcile the goal with what they want, but you also have to test them and use the rehab process, treatment process to put them in scenarios where they're able to determine if they're meeting their goal. And you don't do that just by lying on a table. So you could take.
I don't know if you know our listeners, Doug, but our listeners are awesome, and they definitely wouldn't extrapolate that out of anything that I said. So
they might not, but
the rest of the
internet
internet might take it as we're doing.
You can take anything too far. Obviously, there's a balance between your expertise and giving somebody like what they think they want. But, you know, if somebody truly wants to function at a high level, like you're not going to get them to function at a high level if you just do totally passive things. And if they do get to a high level, then they succeeded in spite of you, not because of you. So there's definitely a balance there.
Yeah.
And it's also, people have every right, like if someone's functioning at the level they want, they have every right to want to come in and just have you do passive things. Now, especially if they're willing to pay for it, whether or not that's medically necessary in like an insurance scenario, that's a different factor. But let's make it really simple and say people are just paying you cash. Like if they want to come in and like they say, look, I'm fine with everything. I can do whatever I want. It just feels really good. And I think that I play tennis or golf better after you give me a massage, then that's totally fine. And you might decide like, look, I don't want to give you a massage for an hour, but as long as it's honest and everyone's transparent about what they want, then I have no issue with that.
Yeah, and some of I do see a lot of like quote unquote healthy individuals in New Jersey, you know, cash clients who are, you know, maybe in season, and I'm seeing them because they throw a baseball like all week, very hard, pretty often, and like I wish when I was their age playing sports that I had somebody to rub my arm, because it just feels so much better and you feel so much more prepared or ready to move the next time you need to throw again. So that's like a big part of the baseball culture, is the manual work that you might do. It is probably more so at like the professional levels where you're getting that you have that resource readily available. But you know, a lot of the kids that I'm working with are able to access me on a regular basis for manual work. And again, it's like, you know, therapists might say like, oh, that's not medically necessary, but it's like, yeah, if it's cash, I'm not dealing with insurance, and they're already on a training program with like, I can see their strength coach out in the gym right there, and they're doing everything else that they're supposed to do. Like, who am I to tell them that, you know, I'm not going to do that because I don't think it's helpful, where I 100% think it's going to be helpful, because if you're sore, getting rubbed down is going to feel really good. It's like if you're sore and you foam roll, like that's going to feel pretty good when you're done. So like, why wouldn't, you know, my thumb or my elbow help as well?
And that's something else that's also just helping the patient achieve their goal and improve their function. You know, in that example, if somebody who wants to be able to throw a baseball pretty hard and do it a lot and do it every X amount of days. So yeah, it's like you're still giving them what they want, where our assessment in that time is like, do they feel better subjectively in the moment, and can they do what they want to be able to do again in a couple of days when they have to go out and pitch again?
Yeah, that's sometimes they actually, like, you'll lose mobility after you go throw 100 pitches, like you might lose some shoulder flexion or whatever, and like then they like really do need it, otherwise it's just going to get worse and worse. So yeah, thank you for that.
Even those examples, Greg, like when you work with those people, you're not coming in and just blindly doing the exact same thing. You still do some sort of brief assessment with those kids.
Right. Yeah, and it typically turns out to be the same thing, because I know them so well, and you know, they tend to have seen me for a while. But yeah, there's always some sort of biomechanical reassessment every time. But yeah, I mean, I could probably name three high school pitchers or college pitchers right now in exactly the spot that they'll be sore after they throw their next outing, because I just know them so well, and they know that it helps them so much to come in and have that treatment. So it's helpful for them.
Yeah, like we always talk about, everything comes down to, you know, what's the intent. So like, I know for me personally, if I had the time right now in my current state, or if I was a professional athlete, I would hire somebody once 100%. Or even a couple of times a week to like, so I could just lay on a table and relax, even knowing full well that whatever change that occurs is totally transient. It's not going to be lasting. It's not creating like a permanent tissue or, you know, histological change, because even if for an hour it's going to make me feel good and make me relax, I would do it. Now, if I did that to somebody else as a professional, I just wouldn't call it medical treatment, and we're not going to like charge an insurance company for that, because it's not tied to like a therapeutic goal. So again, it always comes down to intent. People have the right to want to lay on a table and have somebody rub them and make them feel good. And there are a lot of things that we do that we're chasing a temporary feeling, like even like a surfer, right? That gets this endorphin rush from surfing. They can't surf for like a week straight. So they're doing it temporarily, and they're okay with the fact that it's not going to last forever until the next time they do it. A manual therapy or a passive modality is not different, as long as you're not false advertising and you're saying, well, this is your ACL rehab, because it's not. I mean, it might be a very small part of that, but it's not going to help somebody achieve like a really high functional outcome in isolation. We did a podcast last year with Christy Ashwanden, who wrote a book called Good to Go, and it's a book about recovery that I recommend to everybody. And it's kind of like, she makes the point that all these devices and people, manufacturers, they claim to have these products that like truly promote recovery, when again, recovery is kind of an ambiguous thing. It's very subjective, and it comes down to like the science behind a lot of these things is very, very ambiguous. But if somebody does something and they like it, and even if it temporarily makes them feel good, like as long as we're not making any false claims, like there's nothing wrong with it. In the context of physical therapy and like medical treatment, going for like a massage to feel good, I don't think you could say that you're treating a medical condition by doing that in isolation. But in the right context, there's nothing wrong with it. If that's what people want, and even to your point, Greg, like if someone, let's say, is doing their ACL rehab and they're at like 6 months and they're beyond a point that they're like, insurance company will cover it, they're working with maybe a strength coach where it's more cost effective, they're getting what they need from a functional standpoint, and they want to every 2 weeks get a massage from somebody because it makes them feel good. And even if it's like a placebo, and it just gives them this sense of confidence that like that's helping them recover from the really good training they're doing, like who cares? It's, some of this stuff is just really hard to definitively say like this is what we're doing.
Did you have something, Greg?
That just took me out of my thought process.
I was thinking when you said the transient thing, I just find that like, because there is that like idea in the physical therapy world that like we only want to give interventions that are going to like fix people, and it's going to fix their condition, it's going to fix what they're coming in for. It's like I definitely felt that way when we first started learning and kind of practicing. It's like your goal is to fix someone, but the longer we practice, I don't believe in that idea of fixing anything. I don't think anything is ever fixed. If it's like manual therapy may give a transient sensation that goes away when they leave the building or wherever, but like sometimes it doesn't, sometimes it does. Things need to be done consistently. Like exercise, non-manual techniques are the things that people talk about that can fix somebody and teach them all these new strategies. But we can teach people, like teaching somebody a strategy doesn't necessarily fix what they're coming in for. It doesn't fix their symptoms. It's just giving them tools. And doing manual therapy is just one of the tools that can help people, if it's done consistently, help people feel better for a pretty long period of time. And I think that idea of like things that we do, it's like everything we do in our job is transient. There's a transient effect. If it's trying to get somebody stronger, there is a transient effect to strength. It may last a lot longer than manual therapy does, but ultimately like consistency and habits and movement, it's like those are all the tools that we're trying to give to our people, which is why I really like what you said at the beginning of like all you do is get people to move. Like I completely agree with that. If everybody came in, half the time all I'm trying to do is just take off their training wheels. That's it. Whether it is through really simple exercises, whether it is through manual therapy to make a joint feel better so they feel like they can move, it doesn't really matter what it is. All we're trying to do is just take off the brakes that people are walking around with all the time.
Yeah, and if there's a real fix, if that exists, it's a process. Like you never really, like you might be like formally done with physical therapy where it's like, okay, you can go back and play your sport, but if you don't do anything after that, like maybe you just show up to practice, don't train in the off season, then even if you don't get hurt again, like you're not really prepared. So it's teaching people like habits and a process. And that's why like, yeah, you can discharge somebody. It doesn't mean that you want to create dependency and say you're going to need this forever, but like teaching, like you said, those habits where this stuff never, and even if you don't play a sport, like even if you just want to like have a high quality of life when you're older, like if you stop doing things, like once you stop, then you're done. So even if it's not physical therapy in a formal sense, like if you're not always moving in some kind of a systematic way, then yeah, like then you're finished. I mean, that's all we can really do. That's the process.
Yeah, that's cool.
Yeah, I was going to say, I think you said earlier that if you were a professional athlete, you'd want to sit on a table once a week or lie on a table and get a massage. I was like, I could use that right now without being a professional athlete.
I would do it right now too. Yeah.
Yeah, I would do it daily if I could. But yeah, I mean, that's another part of it too. You mentioned like recovery being very subjective, and we're physical therapists, always focus on the physical piece, but recovery, like if somebody feels like they're getting what they need and they're psychologically and mentally more comfortable, after working with you, like that's a piece of it, and that's part of their recovery as well. So that was all I was really thinking about that I forgot about. So.
Yeah, I would recommend that that podcast with Christy. Maybe we can put it in the
Put it in
notes,
the notes.
because she even talks about like they did a study, people who were like runners, and like after they ran, if they drank a beer or a certain number of beers, that like helped their recovery, and it like and some people it showed that it did and some that it didn't, but then it's like and some of this stuff is common sense, right? Like, do we need research to show if you have like a case of beer after you go for a run and you want to run the next day, probably it's going to hinder you in some way. But like, if you have like one beer, and part of when you have that beer is like you went for a run with a group of friends, and then like while you're unwinding from the run, you're like you're having social interaction, which there's like positive effects to that. Let's say like while you're having that beer, you're eating a meal slowly and enjoying people's company. Like, if there's a recovery element to that, like, is it because you drank the one beer? Because like one beer shouldn't make that much difference one way or the other, right? Like, we're not that fragile, and we're always looking for like that 1% thing. Because we've all seen the bullshit headlines where it's like a study comes out and somebody misinterprets it, and it says like, beer is shown to help recovery in runners. It's like, okay,
Sure.
now all of a sudden beer is a performance enhancing drug, but none of this stuff works in isolation. So again, it's like a lot of it's common sense. If you have one beer and you feel like that helps you to relax, and it also like you're doing it in the company of others, it could be good. If you have like, a 6-pack after you run, unless you have like freak genetics, it's probably going to hurt you, or it's not going to help, So she does a much better job of explaining this than I do, but we're always looking for that 1%. I don't think we're that fragile that like anything in like a very small dose makes that much difference. I think it's more about, like Trevor said, this process and how do you combine all these elements and how do they interact? And that's much harder to quantify. And that's why that's what we do in a clinical sense is we're not ever doing one thing. We're doing a variety of things that have interactive effects that are hard to objectively assess, which is why when a student says, why did you do that? Or how do you know that it works? We're coming full circle here. It's really hard to know because everything's interacting.
Yeah.
Yep. Keep it real.
Real.
Any signing offs from either of you guys?
No, that's it. Great job, host.
Great job, guys. Thanks for tuning in, everybody. We'll see you next time.
As a thank you for listening, we'd like to offer a 10% discount on all products at resilientperformance.com. Please use promo code PODCAST at checkout. That's PODCAST. And I also encourage you to sign up for our mailing list to receive exclusive articles only available by signing up. Thanks for listening.